Thank you. I'd like this to be pretty informal. I have a lot of slides to get through. Some may be of more interest to you than others. So I'd really like to be able to spend the time where you guys would like me to. So please feel free to jump in, ask questions as we're moving along. If something doesn't make sense and you want more information, or if I didn't cover something at all, please feel free to go ahead and interject at any point. So I'm going to be talking primarily about the prevention and the treatment of pressure ulcers. For those of you who have either watched last year's video or attended last year's, some of this is going to be a review. And that's good. And the reason I'm doing that is because most of us, unless you do it all the time, there's certain components you forget. So I hope that as I'm doing it, you go, oh yeah, I remember that. Oh yeah, I remember that. That's great. That's the goal. So eventually you're up here teaching it instead of me. Some of the stuff is going to be new. And I'm going to go into a little more detail than I went in last year as well. So why did I choose pressure ulcers this year? I chose it because 11.9% of the people in our country today have pressure ulcers. And 5% of those happen in acute care hospitals. And I don't think we're any different than those statistics here in Butte, Montana. So we have some room for improvement as a nation, and I'm pretty sure we probably have some room to improve some of our practices here at St. James as well. Those pressure ulcers cost us as a nation over $11 billion a year. And with all of the cuts happening in healthcare funding, if we can even take half of that out because we improve our practices, that's a lot more money we have left to redistribute somewhere else, right? We estimate here at St. James that these pressure ulcers cost us anywhere from $500 to $70,000 per occurrence. CMS, as you guys know, we don't get paid for pressure ulcers that occur in a hospital setting anymore. Did everybody know that? That if you get one, the entire course of the treatment, we eat that. Also, did you guys know that if we identify it appropriately upon admission, that we get paid more money? Did you guys know that? That if we have a patient that comes in that has a pressure ulcer present upon admission, we actually get to increase our reimbursement. So there's some really good value in making sure, A, we're preventing them, but B, we're identifying those appropriately when they're present upon admission. Some research has shown that of trained clinicians, whether it's a PT, an OT, a doctor, a nurse, that only 23 to 58% of the time are we staging pressure ulcers correctly. So we're doing it wrong a lot. And so I'm going to spend a little bit of time going over that. It's going to be a review, but it might be new to somebody. I'm going to kind of skip the purpose because I think the purpose, I think it's fairly obvious why we're here. I am going to review the skin a little bit just because it's always a good review unless you do it all the time. And it has to do with how we're staging pressure ulcers. Or even how you, even though you don't stage venous stasis or arterial ulcers, it identifies partial thickness, full thickness, etc. So the epidermis is the outermost layer of the skin. Right underneath that is the dermis, okay, the second layer. That is what's involved in a stage 1 pressure ulcer, okay? The epidermis and the dermis. Then once you get into this hypodermis here, that subcutaneous layer, now you're into a stage 2, stage 3 pressure ulcer. As you get down here into the deep fascia and the muscle and then the bone, now you're getting into your stage 3s and your stage 4s. So I just wanted to review that. I'm not going to go over this a whole lot, but basically your epidermis, dermis, subcutaneous layer, and then down here is going to be where your stage 4s are. So what's the definition? The National Pressure Ulcer Advisory Panel is pretty obvious. It's skin damage that's caused by pressure or pressure in combination with friction and shear over a bony prominence. Now that's important to keep in mind because we often will incorrectly call a wound a pressure ulcer when it's not a pressure ulcer. It's over a bony prominence as a result of pressure or pressure in combination with shear and friction. I thought this was a great slide to kind of show sort of the physiology of what creates a pressure ulcer. Basically, you get pressure on the skin. And then eventually what happens is you start causing pressure on those little tiny blood vessels. And then those blood vessels get blocked. and then you get tissue ischemia because you're not getting nutrients and you're not getting oxygen, and then eventually the skin dies. Now what else does that sound like? Does that sound just like a heart attack? Same exact thing. You're causing pressure onto the vessels can't deliver nutrients and blood flow, and then you get tissue necrosis. So it's the same thing, you just see it on the outside of the body versus those of us that work in cath lab and get to see it on the inside of the body. Bony prominences, okay, that's kind of a no-brainer. Here's some other sites that people forget about. So if you're lying flat, really skinny people where the back of their tibias stick out, you can get pressure ulcers there. Don't forget about the occiput. Sitting, again, don't forget about the back of the knees. If you have somebody sitting in a wheelchair or sitting in a chair, I'll talk about how long it takes to get a pressure ulcer, but it's not very long. Anybody guess? How long do you need sustained pressure before you get a stage 1 pressure ulcer? What's the time? Less than 2 hours? Anything else?
3 hours.
30 minutes.
30 minutes.
Oh, lying on your side. Don't forget about that. Sometimes we do a really good job and we recognize this. So we turn and position people, and where do they end up with pressure ulcers? Inside of their ankle because we got it laying on the bed, or on their ear, or on their shoulder because we have them positioned too far over. And then here's the other one that we see sometimes. If somebody is really at high risk, would you believe, how many of you seen them get pressure ulcers on the top of their toes from the blankets? Has anybody ever seen that? It happens. So you have to be aware of all of those sites. It can be pressure from anything, anywhere. So how does it present? Now this is how you're going to know, is this a pressure ulcer, an arterial ulcer, a venous ulcer, is it an infection, a cyst, or whatever? So first of all, it's going to be a rounded, crater-like shape with regular edges. It looks like you took a hole puncher and you punched out the hole. What else does that sound a lot like? What else has a very similar clinical presentation? An arterial wound. Why do you think that is? Because both, you're disrupting the arterial blood flow, right? The difference between an arterial wound and a pressure ulcer is you can get an arterial wound anywhere that there's disruption of blood flow. Typically, for pressure ulcers, you're only going to get them over bony prominences, right? So that's your kind of distinction. Usually, they have a dark base, and they don't bleed very much. And then 95% of them, you're going to get over the sacrum, the coccyx, the trochanters, your sit bones, your ischial tuberosities, your heel, and then the outside of your ankle bones. Stats, most of them are in older people. The number 1 site is the sacrum. The number 2 site is the heel. But don't forget about all those other ones too, so don't lose focus. This one, I'm actually not going to spend a whole lot of time on this. Susan talked about there's a whole EPIC documentation skills lab, so I'll let them discuss that more, save our time. Stages and progression. So there's 4 stages that you develop a skin ulcer, and I'm not necessarily talking about a stage 1, stage 2, stage 3, stage 4, although it sort of correlates. But basically your first stage is when you get hyperemia or redness. And that will occur within 30 minutes of sustained pressure anywhere. So if you immediately remove that pressure, then that hyperemia, that hyperemic response will go away in approximately 24 hours. Then if you keep the pressure on, if you don't relieve it, now you're going to move from hyperemia to ischemia. And that's going to occur, depending on the health of the person, somewhere between 2 and 6 hours. The texture at that point, skin's going to start to feel a little bit hard. If you don't remove the pressure at that point, now you've crossed over into kind of the land of no return. Now you're into tissue necrosis. At that stage, it's no longer red and non-blanchable. Now you're looking at it's gray, it's purple, it's dark colored, and now you're suspecting deep tissue injury, right? It's no longer a stage 1 superficial. Now there's probably deep tissue going on because of that necrosis. If you continue the pressure, or depending on the health of the individual, then ulceration is going to happen after that. So I have a whole bunch of slides in here that help stage them just because they all look a little bit different. Stage 1 through, that actually has a stage 5 because they talk about an unstageable, and we'll talk about that in a bit. And I'm just going to zip to the one I like the best. So this shows a stage 1 through a stage 4 pressure ulcer. The stage 1 is non-blanchable erythema. It's red and you touch it and it doesn't blanch. And you can see that it doesn't break through the skin, okay? The epidermis and the dermis, the first two layers, are intact. Okay, a stage 2 pressure ulcer is now when you have disruption of those first two layers, the epidermis and the dermis, which is shown right here. Epidermis, dermis. But the underlayer, the hypodermis and the subcutaneous layer is still intact. Stage 3 is when it's worsening, and now you're jumping into that third layer and you're getting disruption of that third layer. At stage 4 is you've gone all the way through that subcutaneous layer, the fat, and you're getting into muscle, tendon, or bone. Okay? Any questions on that before I move on? This just goes over it all again in another way. These are in your handout, so you can read them. We all learn different ways. So these are just a whole bunch of different ways to present the same information. The reason I'm going over this is because 26% of the time we're not identifying and staging pressure ulcers correctly. Here's another picture of it. So this is an actual clinical picture. Stage 1, stage 2 looks kind of like a rug burn. Stage 3, stage 4. One little tip that you guys can think of, if you're trying to decide, is that a stage 2 or a stage 3? I'm not really sure. Is that sub-Q or is that just the dermis? If it has slough on it, it's always a stage 3. A stage 2 will never have that kind of yellow fibrinous slough. Okay, so that's just one thing you can tuck away in the back of your head to help remember. So now the other two stages, I guess, if it's not a stage 1 or a stage 4, or to a stage 4, it could be unstageable. And that basically means that you can't see the wound. So you don't have any idea how deep it is because it's covered in something necrotic. Whether it's black ash scar or it's yellow, brown, tan, slough, you can't see the base of the wound, so you have no idea how deep it is. Don't guess, just call it an unstageable. The other one is suspected deep tissue injury. So that's when you have this heal and you can't really see it there, but you're like, oh boy, that's bad. The skin's intact, but it's purple or it's black, and I'm pretty sure that's bad. You're right, it is bad. And what a suspected deep tissue injury means is that the skin is still intact, but you're pretty sure that once it opens that it's going to be a deep tissue injury. Probably a stage 3, most likely even a stage 4. I already talked about the stage 2s and the stage 3s. The one other thing I wanted to hit on is in documenting, never backstage a pressure ulcer. So if you have a stage 3 and then it gets better, it doesn't become a stage 2. Even though maybe you've gone from sub-Q and now you're into, it's laid down some granulation and starting to epithelialize, it is a healing stage 3 and you document what you see. It's a healing stage 3 that's filled in granulation tissue, covered the adipose tissue, and now is starting to epithelialize. So document what you, not a backstage, document what you see. That make sense? So heals, I want to talk about those. Heals is the second most common site for pressure ulcers, but it's the #1 most common site for deep tissue injuries. So I want to talk about recognizing that a little bit, and some, again, just a couple of pearls you can tuck away. How bad is it? Well, the color is going to tell you how bad it is. When you're looking at a heel and it's red, all right, we're at the ischemia stage, so I can probably reverse this and keep the skin intact. If you look at it and it's purple, uh-oh, I have an infarction, I have cut off blood supply. That's not good. If it's black, you have tissue necrosis, and you know it's going to open up because there's tissue death underneath the skin, and it's just a matter of time. Now, unavoidable pressure ulcers. That is a whole, different subtext of pressure ulcers, and it's exactly what it says. It's a pressure ulcer that occurs even though you did everything by the book according to best practice. And not all unavoidables are Kennedy terminal ulcers, but some are, so I'm going to talk about those. Some could be somebody, they just have horrible arterial flow, arthrosclerosis, plaque, they're throwing blood clots and they get ulcerations all over their body. And you know that you couldn't do anything to prevent those. Some of them are people who are in multi-system organ failure, and the skin is just another organ, right? And so as other organs are failing, you're going to see their skin fail as well. And a terminal Kennedy ulcer is something pretty specific. You get them while you're dying. Usually occurs on the sacrum. They're usually start pear-shaped. The colors can vary on them. They have irregular borders. Now that's different because remember I talked about regular or standard pressure ulcers. When they start, they have that regular border, that punched out appearance. So if all of a sudden you have a purple, irregular shaped thing over somebody's bottom and they're really sick, you need to be thinking, ooh, end of life, okay? And because that's going to affect how you do your goals. That's going to affect your documentation because this is probably an unpreventable pressure ulcer. They come on suddenly. So you've just done a bottom check 2, 3, 4 hours ago and their bottom looked great. You come in and you clean them up and all of a sudden they have this irregular purple mark on your bottom. That's probably a Kennedy terminal ulcer. And it's usually only in the geriatrics. We don't see this in other terminal patients who aren't geriatrics for some reason. Oftentimes, you'll confuse it with dirt or dried stool, and you'll go in there and you try to rub it off, and you slough off that first layer of skin, and you think, uh-oh. That's another example. I'm dealing with a Kennedy terminal ulcer and an end-of-life ulcer. Death is usually imminent, usually within 24 hours of once you start to see these. And then, as I said, it progresses very rapidly over a period of hours despite doing everything perfectly. Here's some examples. Again, irregular border. Okay, not exactly where you would expect it to start. This one, can you see? I mean, it looks like a butterfly. And see how this one's brown, the other one is purple? And there's one that's purple. Again, irregular borders kind of over the whole darn thing. So how do you document for those? It is very important in your wound documentation to think about end-of-life ulcers or unavoidable ulcers as opposed to the kind that you could have prevented. Because you're opening yourself up, if you document the same way, you're opening yourself up to be sued and to lose that lawsuit, basically. So in these, you don't want to be documenting goals of healed. You don't want to be documenting goals of epithelialize in 2 days and granulate, you know. Basically, you're documenting completely different. And these are some examples that were taken out of some clinical practice guidelines by American Medical Directors Association and CMS. Basically, you want to call it what it is. You know, that healing isn't a goal because of a progressive or irreversible underlying medical condition. Therefore, I do not feel that complete healing is a reasonable goal. This wound represents additional body system failure for a patient who's already in multi-system organ failure. Maybe you're nutritionally supplementing, but the patient's losing weight and you know they're going to open up because they're terminal. Document it. Patient's been losing weight despite appropriate nutritional interventions. A treatment plan, when you're doing those, think about your treatment plan isn't going to be to heal them, right? It's going to be to minimize pain and minimize odor. Or maybe minimize drainage, control drainage. And then the other thing is that you can think of is if you've had a patient who's been repeatedly hospitalized or they've been in and out of the ED and they're having skin breakdown, then you need to document that that pattern may indicate an overall decline or instability in their medical function and healing of this ulcer may not be realistic. Talk to your doctor about it, obviously, whoever the primary care, because they'll guide you. You know, is this person going to heal or not? And they'll let you know. And then make sure your goals reflect it appropriately. So what you see on the outside of the skin is really just the tip of the iceberg because there's a whole lot more going on underneath the skin, right? So the muscle response. The muscle damage to an ulcer is way worse than the damage to the skin because muscle basically needs more blood and more oxygen. The pressure is highest at the muscle fascia, the muscle bone interface. And the ulcer actually starts at the bone interface, not at the skin. So it starts deep and it progresses out other than the other way. So that's something that people need to consider. And I already said that it's really the tip of the iceberg. So now when you're doing your assessment, and your goal right now is preventing a pressure ulcer, look at the stuff that's within your control. And those are the extrinsic factors. Oh, I forgot to hit start for my time. Friction is one extrinsic factor that is under our control. Friction is just rubbing together, okay, rubbing your hands together, a heel rubbing on a sheet, an elbow rubbing on a sheet, you know, like a sheet work, basically. you weaken the skin, you make it more prone for breakdown from a pressure ulcer. Shear is a combination of friction with gravity. Okay, so think about a person sitting up in bed, and you got the head of the bed raised up all the way, and their body sticks to the bed, their skin stays in place, but they slide down over their skin, right? You've kind of all seen that. That's a shear injury. Shear is bad because it stresses and tears the blood vessels. If you don't have good blood vessels to begin with, it doesn't take a lot of pressure to cause a pressure sore. And then shearing is what causes undermining and tunneling in the absence of infection and abscesses and those kinds of things. If it's a straight pressure ulcer and you see undermining, now undermining is when I've got a wound and I can stick my hand and I can kind of go under it like that. A tunnel is when there's a hole, I've got a pressure ulcer and I can stick it through that way. Does that make sense, the difference between undermining and tunneling? So if you see a pressure ulcer on a sacrum or anywhere and they've got undermining and tunneling, you've got to not only address pressure, you have to address the shear that caused the undermining and the tunneling. Another evidence of shear is blisters. You've got a big black or bloody filled blister on a heel. That's not just pressure, that's shear in addition to pressure. Dryness is an extrinsic factor within our control. The outer layer of the skin is about 10 to 15% moisture. When it drops below that, it cracks and it fissures. Obviously, you can't protect the body anymore, and it makes it more prone for breaking down. That's kind of a no-brainer. When you're using lotions, here in the hospital, all of the lotions we use are appropriate, but when you're making recommendations for patients at home, you want to use lotions or creams that have urea or lactic acid in it because those act as moisture binders, but you want to make sure you're putting it on correctly as well. The best time to apply is immediately after bathing when the skin is still moist. You're going to put it on top and you're going to trap that moisture underneath the skin. The body's not making enough moisture on its own, right? So you need to add the moisture and then add the lotion to trap it. The worst product you can use in these situations is a product where water is one of the first couple ingredients. Because basically it's like rebathing the skin, right? You're going to re-strip and cause evaporation and more dryness. Moisture. So dryness is a problem, but being too wet is a problem too. And we know that 65% of all patients with pressure ulcers are also incontinent. We know that if you are incontinent of feces, you have a risk 3 times higher of getting a pressure ulcer than somebody who isn't incontinent of bowel. And why is that? Again, I think it kind of makes sense that the skin gets wet and then it gets soft and it makes it more prone to break down. It also messes up something that we call the acid mantle of the skin. And I'm just curious, how many people have heard of the concept of an acid mantle? A few, anyhow. I know you have. So the skin in its best state is slightly acidic. It has a pH of about 4.5 to 6. And the reason for that is when viruses and bacteria, different substances hit it, that acid kills it off and it provides a nice protection to us. When stool, urine, and sweat hit that, or certain soaps that are more alkaline, when they hit that, they change the pH of your skin, making it less able to fight off those bacteria, those viruses, and less able to protect the body, so it starts to break down. You know, all of those things here are alkaline, which is going to undo the acid mantle of the skin. Not a good thing, right? So your goal is to make sure that you're maintaining the appropriate acid mantle of the skin. So that leads us into perineal dermatitis, not to be confused with pressure ulcers, although they increase your risk of getting a pressure ulcer by up to 2 to 3 times, especially if you have friction, shear, or pressure. It can also be called incontinence-related dermatitis. Keep in mind the most common causes. Number 1 most common cause of diarrhea in a hospital is C. diff. Number 2 is a yeast infection. And if you are using diapers or absorbent pads that are closed, again, you're messing with the pH of the skin. You're changing that acid mantle so they can't fight off the bacteria and the viruses in the stool and the urine and the air, and that's a bad thing. So here's 2 pictures. One is just a pretty straightforward dermatitis. You can see it's red, it's irritated, it's excoriated, but what's different about that picture than that one? What's here that's not there? Anybody? What's that? That's a yeast infection. So there's too much moisture and there's yeast growing. So can you see the little red satellite lesions there that look different, just red excoriated? Can you guys see the difference? That means this person doesn't just have straightforward perineal dermatitis, they have yeast growing on their skin. And if you don't kill that yeast, it's going to progress and open the skin, and it's going to look terrible and be painful in a very rapid amount of time. So you need to be able to differentiate between the two so that you can work to treat them appropriately.
But not a pressure ulcer.
But that's not a pressure ulcer.
Right, okay.
Right? That's a pressure ulcer.
Yeah.
But here, there's no evidence of a pressure ulcer. That's just a dermatitis that has a yeast infection.
Okay.
So how do you treat it? Oftentimes you'll use topical prescription medications that the doctor will prescribe, like nystatin. First thing, you've got to remove the moisture. It likes hot, moist areas, so keep it dry and cool. You can use other dressings. I'm not familiar with the AMD dressing. I don't know, Robin, have you ever used it? We have used this Inner Dry AG. It's sort of like a t-shirt that wicks moisture away, and then it's also impregnated with silver to help combat the yeast, and it actually works really well. You place them in skin folds, under the breast, in the armpit, under a pannus, wherever, and they work really well. But you want to make sure that it's something that can be treated topically by making sure you're looking for other sources. Are you looking in them up? Do they have thrush? Do they have vaginitis? Is it something that maybe requires an oral treatment like diflucan and it's not going to respond? And so consider that during your assessment. Now the stuff that's maybe not in your control, the intrinsic factors, things like malnutrition, dehydration, being critically ill. Unfortunately, the older you are, the less oil you produce on your skin and the more it thins and the more susceptible it is to break down. Low blood pressure, whether you always run low or somebody in a hypotensive trauma. How much tissue oxygen are they getting? Smoking, because it relates right back to the tissue oxygenation. Weight loss, that's important for a couple reasons. One is the body can catabolize itself, eat itself to provide energy. Or two, you don't have enough padding and protection between the bony prominences. Infection and fever are all things you need to be considering when you're trying to assess how high risk is this patient for getting pressure ulcers. And ideally, you want to be treating them all, right? You don't want to just reduce pressure. You want to look at reducing all of those things. So how do you prevent it? So we've talked about what you're going to look at to assess. Now what do you do to prevent it? We want to make sure you're doing a standardized skin assessment. Here at St. James, we do a Braden. And I think, is everybody familiar with the Braden scale? Do I need to go over it?
Can you please go
Sure.
over it?
So it's basically, it's something that's been approved as being a standardized good risk assessment. It has 6 subscales that go over how their sensory perception is, what can they feel, moisture, activity, mobility, nutrition, friction, and shear. Then each section, you're given a score, and then you tally all the scores, and then you're given a total score. The lower the score, the higher your risk. And then we have some standardization tools here that tell you kind of if they're in certain areas, what are some of the things that you should be implementing for them based on their Braden scale. You want to do systematic skin assessments and reassessments. So it's not good enough to assess them upon admission. You need to be assessing that patient at least every shift. More frequently, the higher risk they are and the sicker they are. Because remember, they can come on really quickly, 30 minutes. Or 6 hours for necrosis and ischemia. And then you're going to reduce every risk factor that that patient has that's under your control. You're going to make sure that you're doing patient education on why it's important. You're going to educate the family on why it's important. And then you need to make sure and educate the rest of the clinical team on why it's important, because we all got to be doing the same thing all the time. So positioning, you reduce some of the risk with that. So for bedbound patients, you should be performing a full position change at least every 2 hours, more frequently if they're critically ill or have higher risk. And then at the end, I'm gonna go over a couple of things that St. James has decided to standardize and have available on all the parts to make this easier for everybody. One is a sage and position, turn and position unit. The 5 pillow rule. So you'll sometimes see me document for people at high risk that you're going to use the rule of 30 and the 5 pillow rule. And that's what this means. So the first rule is if they're on their back, you're going to use a pillow under their legs to elevate their heel. Or, as St. James has decided to do, we're going to order a Prevlon heel protector boot that you'll use. I'll go over that at the end as well. If you're